Thank you for the invitation. In this webinar, I will present a clinical case. Next slide, please. This is a 73-year-old male. The patient was fit, so he was doing regular exercise, living quite close to the hospital, and short past medical history, just hypertension control with valsartan. So in 2021, was diagnosed with the CLL, early stage, unmutated IGHV, high subset expression, no symptoms, and the patient was followed without therapy. And 3 years later, the patient complained of fatigue. Physical examination disclosed lymph nodes, quite small, but in all the areas, and then a large spleen by 6 centimeters below the costal margin. Lymphocytes at that time were 45,000. There was an anemia, hemoglobin 103. Platelet count was in the limit. Serological parameters were normal. LDH, beta-2 microglobulin, renal function was also normal. And the flow cytometry was consistent with the CLL, with high-risk phenotype, and the FISH was normal. So this is a quite fit patient, 75 years old now, requiring therapy because of the anemia, fatigue, and splenomegaly. And the question for you in managing this case is, what would you do now? Send the patient to the general physician for control, test for TP53 gene mutations, perform a lymph node biopsy, or run NGS panel, including a variety of driver genes that are involved in CLL. So we can move to the next question. What would you do any imaging study? So in the guidelines, there is no clear statement about the imaging, but nowadays patients are usually managed like the low-grade lymphoma. You would not perform any imaging assessment. The second option, B, is you perform abdominal ultrasonography. The C is the standard CT scan, and the D is a PET CT. So please vote your options. And we can move to the next question related to that case as well. And which is for you the most important parameter, or what's the parameter you are considered the most relevant when selecting therapy? So option A, the wishes of the patient's family, IGHV molecular status, distance from the hospital, or clinical stage. So please vote again. And the fourth question, I think there is another one. Yeah, in that case, so remember, this is 75 years old, fit, with normal organ function, advanced stage CLL, unmutated, TP53 wild type, IPI4. What's your choice of therapy for this patient? You can choose fixed duration therapy like ramucirumab, venetoclax, or obinutuzumab, continuous therapy with a BTK, second generation BTK inhibitor, acalabrutinib or zanubrutinib, or you go for a doublet, ibrutinib plus venetoclax. Okay, so next, in case that this patient has a p53 mutation, so the conditions were the same, unmutated, but p53 is aberrant, so we found the mutation in the sequencing in Sanger. Your choice would be chlorambucil, obinutuzumab, venetoclax, obinutuzumab, continuous therapy, or again, ibrutinib, venetoclax. So you can vote. Okay, so I I think we move now to the guidelines, if I'm not wrong. It's the next exactly. So the ESMO guidelines recommend for that patient, unmutated IGHV, without p53 aberrations. The first choice is fixed duration therapy. This is a fit patient. So probably my choice in Europe would be ibrutinib venetoclax in that patient. In United States is another history. Ibrutinib venetoclax is not approved. Probably continuous therapy with second generation BTK inhibitor or venetoclax or obinutuzumab would be the choice. But probably in that case, in my hospital, we treated that patient with ibrutinib venetoclax fixed duration because it's still considered young patient, 75 years old, fit, and I think we go for a time-limited therapy for this patient. And we are seeing the results. Related to the case, the first test, I fully agree. In the case, I didn't put the p53 sequencing, and I think it's somehow mandatory to perform to test for p53 genetic aberrations. Probably using both FISH plus sequencing. If you can do NGS, fantastic, because the sensitivity is higher. I wouldn't do a lymph node biopsy in that case because it's a standard CLL. There is no sign for transformation. And NGS, panel NGS is interesting, but I think it's still experimental in CLL. So I think we're going to see the results of the next question. Can you put it? Yeah. Imaging, people usually perform CT scan for two reasons, because we are managing patients like a low-grade lymphoma now. And the second thing is that some of the patients are candidate for time-limited therapy with venetoclax. Therefore, we have to assess the bulky of the disease. So we need a good imaging for those patients that are potentially candidate to venetoclax. In that case, there is no sign for transformation, so I think there is no indication for a PET-CT. The next question was related to the most important parameter in that case. I think among the ones that I listed here, the most relevant parameter, as you mainly vote, was IGHV molecular status. Clinical stage is still important, but it's not detecting the type of therapy we are going to use. And the next polling question was, the choice of therapy. We have here three possibilities. Venetoclax or obinutuzumab is a good choice. It's time-limited therapy for a young patient. Continuous therapy is also a good approach for those patients. Unmutated IGHV, and the ones that we are choosing now, ibrutinib venetoclax, I think is again another choice. We don't know which one is better, as Dr. Gia mentioned. We are still missing the results of the CLL 70 that is going to shed some light on this, whether continuous or time-limited therapy are better. And the next was the same patient with p53. And in that case, as we can see in a few slides, I think the best option now, or the most recommended option, is a continuous therapy with BTK inhibitor. And there is also the possibility to use ibrutinib venetoclax. I think the results with venetoclax or obinutuzumab in p53 aberrant patients are not excellent. So I think the two options, Acala continuous or ibrutinib venetoclax, would be the preferred choice. Okay, so I think we can move to the next slide. Whether Paula already mentioned the GLOW trial. You see here the results of the GLOW trial. That was ibrutinib venetoclax compared to chlorambucil obinutuzumab in unmutated patients. And you see here that this combination is excellent. At almost 4 years, 70% of the patients with unmutated IGHV are treatment-free. So therefore, it's a good approach for these patients. Next is again focusing on unmutated IGHV. You see here the activity of the different BTK inhibitors. And again, this continuous approach for these genetic high-risk patients is excellent. Ibrutinib, acala, or zanubrutinib are providing an excellent and prolonged progression-free survival in this high-risk population. The next slide is showing the CLL14, that is venetoclax plus obinutuzumab. And you see here that the results in unmutated IGHV, this is the green dashed line, are not as good as the ones obtained in mutated IGHVs. Therefore, the statement is that CLL obinutuzumab venetoclax is not a good approach for these high-risk genetic patients or with biology patients. CLL13 already Paolo mentioned, and the CAPTIVATE in high-risk CLL. These bars were already shown. I'm focusing on patients with p53 or unmutated. The results are excellent with this ibrutinib venetoclax. These patients were patients that were fit, were in good condition, and they attain an excellent response and progression-free survival, even with p53 genetic abnormalities. So in the next slide, I think I'm concluding the p53 and IGHV molecular status should be assessed. I would say that it's mandatory to be assessed prior any therapy in CLL. Continuous therapy with covalent BTK inhibitors are a good approach, and also the combination of these BTK inhibitors plus venetoclax are also an excellent approach for these patients. Venetoclax plus anti-CD20, it seems that had lower activity in patients with biological high-risk CLL. And again, fixed duration ibrutinib venetoclax demonstrates activity in patients with high-risk CLL, although the follow-up is still short, so we need more follow-up to know the final results of this doublet combination. I think as Paolo mentioned, at ASH probably will have excellent results with acalabrutinib plus venetoclax, that in my opinion would be probably the future in of these doublets for high-risk patients. Thank you.